Okay, and we are now streaming live. So good morning, good evening, good night, depending on where you are in the world. Welcome to this first session of the Decolonizing Global Health Seminar Series, hosted by Georgetown University's Walsh School of Foreign Service, Science, Technology, and International Affairs program, in collaboration with, sorry about that, with the Center for Global Health Science and Security. As the seminar series is being held as part of these academic programs, we are joined in the Zoom room by a number of Georgetown students who will be able to ask questions directly during the Q&A at the end of the lecture. For those of you who are watching live on YouTube, please add your questions into the comments section. We'll be moderating that, and if there's time, we'll include those questions for the speaker at the end as well. So thank you so much, and please remember to subscribe to our channel for this recording and also for future content. So just before we get started, I want to provide a tiny bit of context around the term decolonization. It's gained momentum in recent years, stemming from frustrations at the implicit and explicit ways in which Western cultural and educational hegemony has pervaded virtually all disciplines. In the discipline that we call global health, false narratives of objectivity and universality have clouded the realities of historical roots in European and North American colonial endeavors. Throughout this seminar series, we are hoping to provide an opportunity to learn more about the concept of decolonization and how it's being applied to improve equity and redress past wrongs across research, policy, and practice. So these discussions are not meant to be easy, and it's only through pushing at the boundaries of comfort that we can make progress. As such, I encourage everyone participating in this discussion to lean into that discomfort, but also to practice the gift of grace. We are all on a path of learning and may be starting from very different places. As a colleague of mine eloquently put it recently, let's recognize that risk-taking and courage are needed to achieve sustainable change, and systems of power perpetuate themselves. So with that, it is my extraordinary pleasure to introduce Professor Madhukar Pai. He's our guest speaker for today, and I'm absolutely thrilled that he is the one who will be kicking off this seminar series on decolonization of global health. There are a few other names so readily recognizable in this space than his, especially on Twitter, where he has been a great source of inspiration for me across the last several months and years. In his day job, Professor Pai is one of the world's leading experts on tuberculosis. He is the director of the McGill Center for TB, as well as the Canada Research Chair in Epidemiology and Global Health at McGill University. His research focuses mainly on improving the diagnosis and treatment of tuberculosis, especially in high-burden countries. And he serves on a number of high-profile scientific and advisory boards. With over 300 publications and receiving top academic recognition in Canada and abroad, we are truly privileged to have the opportunity to hear his perspectives today on global health and why it needs a makeover. So with that, I'd like to hand over, please, to Professor Pai.
Hi, can you see my slides now? All right, happy to be with you, and thank you so much again for the kind invitation to kick off your seminar series. What I want to do is begin with some reflection on where I've come from and where I am at in my career and why that is relevant to this particular discussion. In other words, what qualifies me to speak about this? I'm not the world's expert on colonial history or decolonization by any means. I'm more of someone who was in the trenches and dealing with some tensions and conflicts, which I've been talking about and writing about, more to clarify my own head about where I am, what I am doing, and also reflect on whether I might be contributing to some problems knowingly or unknowingly. So in that spirit, I don't know if you can see this old picture. That's me at this corner here. Back when I was doing my public health training in a small town in South India called Vellore, the same place where I was born and raised. And then these were the kind of white vehicles we used to take into the villages to do work on maternal and child health. I did leprosy work, I did TB work, I did malaria work, I investigated outbreaks. It was an interesting, wonderful life doing clinical medicine and public health in India. But I do remember, even when I was a young resident, an endless stream of American and European students, white American European students who would visit us, spend a few weeks, 3 weeks, 4 weeks, and go back. And I still remember that they would all publish their little studies in good journals. None of us got to publish anything. And we used to complain about it because we felt like we knew much more about India, we knew much more about the problems we were dealing with. And yet these foreign students seem to get more time and able to do things that we could not do. So I don't know what made me uncomfortable in those days, but fast forward years later, I ended up becoming the director of global health at McGill, and I ended up promoting lots of Canadian students to go to India and to go to sub-Saharan Africa to do these research fellowships or internships and whatnot. So, you know, in some ways, life has come a full circle, right? So I keep wondering, so am I in some ways now kind of perpetuating the same kind of issues that I was worried about in the past? And I think I should acknowledge that yes, although I spent the first 30 years of my life living and working in India, I do now speak from a position of privilege. I'm privileged in many ways. I'm a male, I'm a professor. I live in a wonderful high-income country called Canada, which I've grown to appreciate a lot in the last, during this crisis. And so I do have a lot of privilege now, and it does make me more aware that this is a discussion worth having, you know, that people of privilege seem to get more privileged. And that is, in fact, a running theme of global health, as you will see from the data I'm going to share with you. So who gets to talk in global health is very seriously connected to who is privileged and where they're coming from. And I think if you are at Georgetown University, or like me, you are at McGill University in Canada, let's begin by acknowledging that we are among the most privileged people on the planet. We have money, we have education, we work and live in extraordinarily powerful schools and universities. And I think recognizing that, I think is actually quite critical to have any meaningful discussion. Just as recognizing one's privilege of being white is necessary to even talk about racism, right? So we have to start somewhere, or recognizing the privileges that come from being a male is critical to talk about, talk about gender balance and so on and so forth. So this is one of my all-time favorite movies, The Matrix. And I think just as Morpheus gave Neo a choice of a red pill or a blue pill, I think there is a blue pill version of global health, and there's a red pill version of global health. The blue pill version of global health, which we could swallow, and I think we might have swallowed it, and I think we do teach it like that, and I may have taught it like that myself. And the blue pill version would say something like, yes, global health does have colonial roots, for sure. Everybody recognizes that. Every global health textbook talks about the colonial history of global health. But today we are in a much better, happier place, right? Colonialism is not that big a deal anymore. We care a lot about equity in global health. It's the heart of what we do in global health. We believe in reciprocity. We endorse bidirectional partnerships. We are not into this exploitative, extractive type of colonial practices in the past. And to some extent, I think there is some truth in this. The situation is way better than what it was in the past. But if you kind of scratch the surface of this narrative that is often portrayed in many uncritical global health courses or uncritical global health lectures, then I think you start to see that the argument is a bit fragile, and I'll explain to you with data as to why that is. So I think we should now ask what might be a red pill version of global health. In other words, what's the reality? So the reality, I think, could come from multiple sources. I think if we speak to people who are living and working in low and middle income countries or in underserved communities, even within US or North America, we will see or hear a different version. What I'm choosing to offer you is more a data-based approach to where I think the red pill version might be. I think I'm an epidemiologist, so I like to think about data or share data. And I think the data are so powerful that it leaves very little room for real discussion, in the sense that it's overwhelming, the clarity of the data that I'm going to show you. Let me know if you agree, having seen the data. And as I've been digging into the data behind what's happening in global health today, in other words, what's the reality, what's the red pill version, I've been kind of blogging along my way, right? Every time I learn something, I blog about it, I write about it, I share it, I get feedback, and I think about it, and I go back and I write something else. So this is a series of blogs I've been writing about what global health is or what might be problematic with global health. And you're welcome to go and see all of them in one place, and it's all free access. There is no paywall here. So I want to start by kind of cutting it up into bite-sized data chunks. So the first issue is, as they often say, you have to really ask who is in the room, right? Who is in the room and who calls the shots, right? So let's ask who is in the room in global health and who calls the shots in global health. That's a great place to begin, right? Because this is a very, very famous picture of the Berlin Conference of 1884, where a bunch of white guys carved up Africa and decided that that's how they're going to run the world, right? Obviously, there's not a single African in the room, and Africans were not consulted on how they were going to get carved up. That's the phenomenally powerful colonial story that continues to haunt Africa even today, right? There is no aspect of life in Africa that is not colored by this devastating colonial impact that still reverberates on the continent. I mean, what's happening in DRC right now, in some ways, can be directly traced back to the craziness that happened in this room by these white guys and what they did. So let's be clear that this is critical. If we don't talk about who calls the shots in global health, we'll never quite understand the power imbalance in global health. So I was thrilled when the Global Health 50/50 report came out this year. So this is a report that a team has been working on for many years. They primarily looked at it from a gender balance perspective, right? So they kept pointing out, like, global health is imbalanced. There's many more men, so it's not 50/50. It's the seriously imbalanced in terms of gender, and that's factually true. But this year, in addition to gender, they also collected very important data on who runs global health organizations, right? And then who are they? Where are they from, right? And that is powerful, because the intersectionality is critical here, right? Because gender is only one aspect of the imbalance. For sure, it's an important aspect, but it's not just gender, right? So here is data that they showed of nearly 200 global health organizations around the world. WHO, Gates Foundation, PEPFAR, Global Fund, UNITAID, PATH, CHAI, you name it, it's all in this, okay? And look at where they are headquartered. In other words, where is the room located physically, right? And you can see overwhelmingly, nearly 90% of global health organizations are headquartered in Europe and North America, right? I think just 4 or 5 cities could probably account for almost all of this: Geneva, New York, London, Seattle, right? And Washington, DC, perhaps, right? These are places where there is immense accumulation of power, right? The ability to do things is primarily run out of these places, right? There's very few global health organizations that are actually headquartered outside of these places. So this is powerful. This infographic in one stroke kind of tells you where is the action really happening. And if you're not in that room, your ability to influence decision making is very limited. We all know that, right? Where if you're not in the room, you're not in the room. Okay, next. So even if the rooms are primarily located in high income countries like Europe and North America, who's sitting around the board, right? So these are composition of CEOs of those organizations or chairs of the board. We know CEOs and board chairs are immensely powerful, right? That's true in the corporate world, and it's true even in global health organizations. And here goes. Out of every 20 leaders, that is CEOs or board chairs, 14 are men, okay? Overwhelmingly men, which is not new news because the same report has been tracking that for many years. But now, in addition to the fact that they are overwhelmingly men, you have fascinating data. Out of 20, 17 are nationals of high income countries. 17 are high income country folks. There are only 3 who are nationals of low and middle income countries. And most of the people who are calling the shots, they also reported in this, are white men and older white men. Okay, so if you ask me who's running global health, I think the quick tweet version of it is older white men who are from high income countries. That's basically, and they even track back that most of them are from a few elite universities like Harvard. Okay, that's the level of detail that this particular report showed. So that's basically who is calling the shots in terms of where global health organizations are and who's making big decisions. Colonial era institutions have not disappeared. They are very much all around us. If you look at these logos, these are not the only ones by any metric. These are all colonial era institutions. You look at the London School, you look at the Landsat, you look at the Hopkins, you look at the Swiss Tropical Institute, you look at the British MRC, Rockefeller Foundation, they all have histories that go back to the colonial period, right? In fact, tropical medicine was about keeping white people alive in the tropics, right? To put it bluntly, that's what tropical medicine was all about. And some of these institutions still have tropical medicine in the title of their schools, and that colonial history has not disappeared. And many of them work very much along colonial lines, right? So if they had some country that they had a colonial field site in the past, they would still work there today, right? That's how information and money continues to flow even as we speak. And powerful groups like the Landsat and Richard Horton, the editor of Landsat himself, has written about this, right? He has admitted that Landsat is a colonial era institution that needs to reform. And if you look at Landsat commissions, so I've been a part of 3 Landsat commissions. And if you look at, and somebody just published it this year, this paper, showing that most Lancet commissions that they looked at have very little representation outside of North America or Europe, right? So Lancet commissions are primarily driven by, these are breakdown of commissioners. They're primarily people like us in high income countries and coming from a place of privilege. And I had one of my students pull out 59 published Lancet commissions that is on their website. And 90% of the Lancet commissions were led, or secretariats were in high income countries. So who gets to be on these high profile commissions? Again, it's people like us who are privileged, living and working in institutions in high income countries. The next thing we should ask, so we know where the rooms are and who is in the room and who's calling the shots in the room. Now let's ask who's got the money, right? Money speaks, money offers, buys privilege. And with money, one can do ridiculous things by sheer brute force, even if nobody cares about it, right? So money is so critical. And for financing of global health, if you follow the money trail, so to speak, it couldn't be clearer, right? This is financing of global health from Global Burden of Disease, IHME data. the most recent one I could find. So if you look at global health financing, which is about $40 billion for the year 2018, you can see here very nicely, the biggest contributor for global health money is the United States, right? Gigantic chunk of it comes from the US, which is why I think what is happening in US now has phenomenal consequences for global health, right? What Trump is doing and the way the current administration is cutting global health money has incredible implications for all aspects of global health. So US, UK, along very familiar lines, Germany, France, Canada, Australia, basically think of it as a G7, right? These are the dominant elephants in the room when it comes to who controls the money flows. And then there are private philanthropies within them. There's Gates Foundation, USAID. USAID is part of the US, but Gates Foundation, Rockefeller, Wellcome Trust, all of them are philanthropies. And that's where gigantic amount of money comes from. So those who give the money call the shots, right? There's no other way to say it, right? When you control the money flows, you have incredible influence on what gets done, how it gets done, who gets to do it, who gets to spend the money is all dictated by people who control the money flows. Next, we know monies are coming from high-income countries. Who is publishing all the global health work that we talk about, that we write about? Who's in the Lancet? Who's in the New England Journal of Medicine? Who gets to hog the high headlines in global health publishing? So here is a series of studies. I mean, I haven't even captured all of them. I've only captured some of them, but the data are just incredibly overwhelming. The easiest way for me to summarize this is to use the headlines from the BMJ Global Health paper by Bethany Head Gauthier and Jimmy Wallmink and colleagues. Stuck in the middle is what they called it, right? Stuck in the middle basically means the beautiful coveted pole positions of authorship, first authorship and last authorship, invariably go to people like us in high income countries, right? And the places where the research is actually done in low and middle income countries, sub-Saharan Africa, wherever that might be, those authors, if they are on the paper at all, generally are in the middle, right? They get middle authorship. The first and senior authorship usually is captured by folks like us in high income countries. And the fact that this is true across the board, regardless of which subspecialty you look at, whether you look at pediatric research in global health, you look at maternal child health research in global health, you look at specific infectious diseases, you look at authorship in a specific journal like Lancet Global Health, it doesn't matter. The findings are consistent across the board, okay? Very powerful data that global health research productivity or output is dominated by folks in high income countries. Who edits the journals that we are talking about, right? Who is calling the shots on who gets to publish in the first place? And we know editors and editorial boards are very powerful, right? They're gatekeepers, right? So if Lancet editors don't like what you've written, you're never going to get to publish in Lancet, right? Even if it's a great study, you will have no ability to publish in such journals. So here, my team published a study in BMJ Global Health. You can see there at the top. Another team from India did a very similar piece of analysis, also published in BMJ Global Health. And the results are stunningly consistent across both studies. Let's just take the study that we did. We looked at a dozen journals with global health in the title, for Christ's sakes, okay? In other words, it's Lancet Global Health, BMJ Global Health, International Health. Even when you have global health in the title, which means that the journal should care about equity and diversity and representation, we found that the overwhelming number of editors-in-chief were in high-income countries, and the overwhelming numbers of editorial board members were men in high-income countries. Mm-hmm. And who was least represented? Women from low and middle income countries were mostly missing from editorial boards. And we practically never found an editor-in-chief who's actually from a low and middle income country. So even though these journals claim to be there about global health, in practice, they have not diversified their editorial boards. Some of them have recognized it and they're trying to change. For example, we shared all our research findings we shared with the boards of those 12 journals that we looked at. Some of them did come back and say, thank you for pointing this out. We will increase the diversity in our boards, because they were not apparently aware of how imbalanced their boards are. And Landsat put out a statement that they're going to achieve gender balance or parity within the next year or so. And I'm hoping that they will also think about including voices from low and middle income countries if they really care about global health. So where is research shared, right? So all of us go to conferences, we like to present in meetings. And I just did a very quick analysis of some big global health or global health related conferences just to see where the action is happening. Take a look at my own field, the world's biggest TB conference. 80% of our meetings have been held in high income countries, right? AIDS conferences, 80% in high income countries. There's a malaria conference called the Gordon Research Conference on Malaria. 100% of malaria meetings have been held in high income countries. Think about it, it's complete bonkers, right? You hold malaria meetings in countries where there is zero malaria. Right? What's the whole point, right? What are we trying to do here? And why is there not even some reflexivity on how stupid this all sounds, right? Who are we doing these meetings for? And who is even getting a shot at attending these meetings? So 100% of CUGH conferences are held in US. So it's no surprise if you go to a CUGH conference, you basically see mostly Americans talking about global health, right? Which is fine, but is that what we mean by equity? Is that what diversity means? Is that truly distributive? Those are questions I think we should be asking, right? And tropical medicine, 100% of the American Society of Tropical Medicine conferences are held in high-income countries. Now, thankfully this year, because of the pandemic, some of these have gone completely online. It'll be fascinating to see whether one good thing that comes out of this pandemic is that these conferences are now more accessible to people around the world, right? That it's no longer the elite who can afford to fly to UK or London or Washington, DC, who gets to sit around and present at these conferences. And why does this matter, right? Why is having meetings in Montreal or DC or Seattle or London or New York a problem? Because many people we care about or we talk about or we study in low and middle countries will not even get a visa to enter our countries. US and UK are among the most hostile countries in the world for someone to get a visa. How do I know that? Well, when I applied for my US visa from India, my visa was denied in 30 seconds. So I know how much it hurt me and how much it made me doubt my own abilities, right? That I couldn't even get a visa, even though I was invited by Hopkins. It didn't matter, right? I was denied within seconds. And the same thing happens even today. And right now, this year, we all know the visa ban that Trump has imposed and how devastating this can be. So right now, even Canada, right? You would think that Canada is a sensible country. It is a sensible country by comparison, but I can assure you, we've had incredible difficulties for folks in Africa to visit Canada, right? So even my own government doesn't care about global health from that perspective, right? So what is the point in holding meetings when the people we care the most about can't even get a shot at entering the country? What is the point? Who are we doing these meetings for? We just want to listen to each other, then that's fine, right? But if we really care about global health, then we got to figure out how and who gets to present and where these meetings are happening. And then more recently, my team published this analysis in BMJ Global Health, where we asked, okay, there's a whole slew of global health degrees now, right? Masters in global health. So we said, let's look at where these degrees are located and how much it will cost. So when I was in India and I wanted to do my PhD in the US, I could not even dream of studying in the US, not even dream, right? I didn't even have enough money to get on a plane to fly to the US, right? I had to borrow. So, which means how accessible these degrees are really makes a big difference, right? So, here's what we found. We found of the 40 plus global health master's degrees that we were able to locate, and overwhelming numbers are located in North America and Europe, right? It's the same pattern, right? You've seen similar looking graphs already. Nothing changes, right? Europe and North America dominate every aspect of global health. And within Europe and North America, it's usually UK that dominates, and there's US that dominates. So I would reduce all this to just US and UK, right? Two countries with outsized domination and influence on every aspect of global health. So you can look at the tuition fee for a master's degree in global health in the US. It's about $60,000 for a master's degree in global health. Now, how many people in low-income countries do you think could afford 60,000 US dollars for a master's degrees in global health, right? And this is completely mad, in part because the degree itself says global health, and yet it would be completely inaccessible to people that we really, really care about, right? So then who gets to study in these programs? Well, it's no surprise. It's mostly people in US, in Canada, in Europe who are doing these degree programs. So what does that mean? Well, the already privileged people who are living in high income countries get to do global health degrees and will become leaders of global health in future. So we are almost privileging the more privileged to continue dominating global health in the years to come because of the way we've structured our educational offerings. Even online degree programs are almost full fees for many students in low and middle income countries. For sure, some of these schools, maybe yours and mine, might give scholarships or fee waivers and all of that stuff. But the overwhelming conclusion is there is a mismatch between where global health training is desperately needed and where global health training is actually happening. And who is getting educated is different from who desperately needs that education. And if we don't kind of rethink the whole educational paradigm in global health, then we will continue to perpetuate and privilege people who are already very privileged, in my opinion. And then I did a couple of analysis, which you're welcome to read, on reciprocity, because we keep hearing that global health is very reciprocal today, right? That we are kind of even, right? That is, we do work in low and middle income countries, but they also benefit and they get to do a lot of things and reciprocate and all that. Unfortunately, at the end of my analysis, and I concluded in this piece, that reciprocity is far from reality, right? In every walk of global health partnerships, it's the partners in high income countries like us who benefit the most, right? If you look at students, which student body benefits the most? It's students like you. It's students like my students, right? Students who are already in a privileged high income country university dominate in every aspect of global health partnerships. Let's ask a simple question. For every McGill student that goes to, say, sub-Saharan Africa, how many African students have we hosted at McGill? Same thing for Georgetown U. For every Georgetown U student that goes, how many students from sub-Saharan Africa has Georgetown hosted? Very few people are able to give me that ratio, that reciprocity index, right? Whatever we could call them. Is it 1-to-1? Absolutely not. Is it maybe 10 American or Canadian students to one African student? I don't know. But from all indications, it's lopsided, right? It's mostly our students who benefit. And you already saw from partnerships, publications are dominated by us, right? So students who benefit are primarily here. Publications are dominated by us. And all this means that partnerships are just not equal, far from equal. It's a long way to go before we can claim to be bidirectional and reciprocal. And then in the current context of Black Lives Matter, I wanted to kind of ask this question. So just because an organization claims to be working in global health, a noble cause, right? WHO, PEPFAR, Global Fund, UNAIDS, Médecins Sans Frontières, right? Doctors Without Borders. They're all doing great work. Does that automatically mean they are anti-racist, right? That they don't have racism in them? But you already saw from earlier data who is dominating these organizations. So if these organizations are dominated by predominantly white folks, predominantly men from high-income countries, could they be free of racism is a question that I'm trying to get at. And then I was just stunned to see report after report after report of how many of these global health organizations are dealing with racism, outright sexism, discrimination against BIPOC folks, right? Now, it's stunning. Médecins Sans Frontières right now, this year, has admitted that they are a deeply problematic organization because of how they are structured and that they are institutionally racist. Okay, MSF. And I'm not at all saying MSF is not doing great work. They're doing stunning work, right? And yet, because it's an organization that is inherently dominated by white people in Europe, right? They have not been able to overcome institutional racism, which is why if you have an organization that is inherently run by white people from high-income countries, no matter how hard you try, you will struggle to ensure that it is anti-racist, right? Because you fundamentally not made the structure diverse, equitable by any means, and it completely starts coming back. Like Women Deliver is an organization, right, about women's empowerment, and Women's Deliver has a racism issue. Médecins Sans Frontières, UNAIDS was investigated for outright sexual harassment. UNAIDS, right? It's about HIV, reproductive rights. And even UNAIDS couldn't find a way to quell this problem and address it head on, right? WHO, United Nations, for Christ's sakes, right? Racism within United Nations. None of these agencies can claim to be free of racism. They have to really ask structurally what's wrong and try and address them. So I think, and it all ties to who is in the room, who gets to call the shots, and where that power and control comes from, right? Because power and privilege has a lot to do with racism. So I hope you are as convinced as I am, because these are really data that I shared with you, not my personal opinion. I will share my personal opinions too, but the data to me suggests that every single aspect of global health is dominated by folks like us, right? Those who are living, working in high-income countries, and we clearly benefit the most from global health, right? Every aspect of global health, we benefit. We are at the front, we are the leaders, we control the purse strings, we have a chokehold on what gets decided and how gets things done. And that's the blunt truth, right? So if you wish, this is a modern version of the white man's burden, right? It's not as stark as it is, but it's insidious in the sense that it pervades every aspect of global health, right? And even good intentioned people are unknowingly contributing to this because they're part of a structure that privileges them even further, right? So these are not necessarily bad people, right? They're not necessarily intending to dominate, but in practice, the way the structure is and the incentives work out, the domination is quite obvious and evident if you look at the data. So now where comes the question, so what on earth do we do about this, right? So I think obviously taking the red pill and understanding the reality helps us, right? We need to read more about these problems. We need to discuss more. We need to have critical global health courses. So your course, which is explicitly about decolonizing global health, is a critical global health class. And the fact that you're starting off with a talk like this tells me that you're willing and open to be uncomfortable and to learn from it, right? To small bits of research of the nature that I've shown you, right? It's just a simple question. Who's in the room? Where's the room? Who's calling the shots? Who follow the money trail? And you start seeing what the realities of global health really are. And I have a few more suggestions. So this, it's so sad, right? So if you how many of us have been, outraged at these all male panels, right? So here is a panel of women's reproductive rights, and it's like 7 men on the stage, right? And it kind of totally boggles my mind that these 7 men on the panel talking about women's reproductive rights don't even have the ability to just hit the pause button and say, what the hell is wrong with this picture, right? What gives us the insight or the lived experience to talk about this issue, right? In which world is this considered acceptable? But yet, such pictures keep popping up all the time. These all-male panels are not some figment of our imagination. You see them every single damn day, which means something is fundamentally wrong with people's inability to perceive this warped world that they're living in, right? So I think just as we are starting to call out all male panels, right, and name and shame them, we also need to start asking if it's an all high income country panel on a global health topic today. Is that fair, right? So sometimes this shouldn't shock you at all. The entire panel will be about malaria in sub-Saharan Africa, and you'll have 6 white people talking about malaria in sub-Saharan Africa. In which world is that fair and just? Not just because fair and just, but also the question, are they the ones really suffering from malaria? Are they the ones dealing with malaria on a daily basis? If not, whose voice should be on that panel? Who should be telling us how malaria is killing people in Africa and what the solutions for malaria are? And yet, you will repeatedly find that even in our own world of global health, we somehow think that we are better able to speak about a topic which is innately not ours to speak about because we are not in the front lines. We don't have the lived experience. We're not dealing with the consequences of it. And we don't have the best solutions because we are far away from the problem, right? Sitting in Montreal, how good can my solution be for a malaria problem in Uganda, right? Shouldn't a Ugandan tell me what the malaria solution for Uganda should be? So if that is the case, then I'm asking, innately, in every aspect of global health, given what you've seen in terms of data, should folks like us not actively practice the art of leaning out? Because we're so leaned in, right? We have a chokehold on every aspect of global health. We have a stranglehold on all aspects of global health. Should we not loosen that grip, step back and say our job is really to not lead on every damn thing, but allow people who really are at the front lines to be leaders. And we have a different role right now, and that should be one of an enabler or an ally, right? We now talk about allyship in the racism struggle, right? So how can we be, if you're not a Black person, how can you be a good ally to Black people in their struggle to get justice, right? If I'm a male, can I not be a good ally in the struggle for women to get their fair share, right? Along the same lines, if I'm a straight person, could I not be an ally for LGBTQ communities? I'm asking us to think along very similar lines in global health. For all of us in high income countries who are privileged, should our role be more of being good allies, not someone who's capturing the entire real estate, the money, and hogging all the limelight and credit? This will require a dramatic shift in how we think, how our universities work, how our authorship is valued, how our CVs are judged, who gets grants, where the money goes. This requires a dramatic refocusing of what global health really means. But I would like us to think a little bit about what it means to lean out. Should we cede our spot and say, okay, yes, I could speak about malaria, but I would rather that you invite so-and-so, a woman from Africa to speak about malaria, right? Because that would be a way of saying, I'm going to cede my seat to someone who actually will give a better job than I can, because that person is closer to the problem and closer to the solution, right? And I think this pandemic, whether we like it or not, people have been, we've all now inward looking in this pandemic, right? All Americans are worried about what's happening in America. All Britishers are worried about what the hell is happening in UK. So suddenly everybody is abandoned. Low and middle income countries, everybody is abandoned Africa to their own wits. Let them solve their own COVID problem. So folks in Africa are saying, okay, great, fine. These people are out. Let's just do our job ourselves, right? So they're saying it's a chance for us to be more autonomous and less reliant on the West to come and save us. We will save ourselves from COVID because nobody's coming to save us right now, right? They're all busy looking after their own problems. So whether this pandemic helps in some way releasing the chokehold that we have in global health is something worth considering. We are all not traveling right now, right? We're basically allowing whatever is happening there to happen, and they are figuring it out as they go along, and Africa seems to be doing better than many parts of the world. So I don't know what amount of that is real, what amount that is data paucity, but it's certainly something that they're writing about. And so I wrote a piece on whether along the same lines, will this pandemic help us completely rethink global health? Can we imagine a better global health than what we have today? And I've written a little bit about the positive aspects. I think everybody understands the importance of health, global solidarity, public health matters, self-reliance among LMIC. But I'm super worried about the negative impact of this pandemic. As much as I would like to think that this pandemic will be in some ways good for global health, I have a long list of concerns. First is we've already seen what the US government has done, right? Withdrawing from WHO. Disastrous to do that in the midst of a pandemic, to cut funding to WHO. UK has slashed foreign aid already, right? Because suddenly everybody is worried about their internal economy, the recession that they're dealing with, and everybody is tightening their purse strings. And international aid is going to take a huge hit, I worry, in the coming years. Now, in some ways, you could say, okay, fine, we don't need aid, right? But then so many low-income countries are so reliant on aid that if you suddenly abandon them, what happens to them, right? What happens to HIV treatment in sub-Saharan Africa if PEPFAR and USAID and others were to pull out, right? What happens to all the investments already made, right? So, and even as the need in some way for aid is going up because of the pandemic crisis, the low-income countries themselves are dealing with devastating impacts on their economies. They're being pushed into poverty, right? Take a look at this estimate. 13 million Africans are being pushed into extreme poverty. So you have this absolutely crazy situation where, if anything, aid should go up in this crisis because there's a need for it. And that's exactly not what's happening. Aid is likely to contract. And that scares the hell out of me, because now we're looking at an even more inequitable world, right? Because yes, we are also facing devastating consequences to our economies in high income countries, but we have the ability to withstand it, right? We can dig deep and come out of it. What happens to low income countries that were already on the edge, right? And look what happens to all other areas of global health that are getting devastated right now. Malaria mortality is expected to double in sub-Saharan Africa this year. Millions of unintended pregnancies. Millions of kids have not even received routine vaccination because of lockdowns and COVID-19. We're expecting huge numbers of maternal deaths and child deaths in the coming years. In other words, COVID just because there's COVID doesn't mean other disease areas have disappeared, right? TB is still running riot, HIV is still running riot, people still need antiretrovirals. So I worry so much about what COVID has done to global health, every aspect of global health. So in my own field, I think about it like this. We were trying to end TB by 2030. And we thought we were climbing a mountain. I think of that mountain now has grown into Mount Everest, right? I think the same is true for people working in malaria. Same is true for people working in non-communicable diseases, mental health. Every single global health challenge has just multiplied manyfold because of COVID's damage, right? So if anything, global health needs many, many more people who are willing to roll up their sleeves, get in and really play a big role in the coming years. But I ask myself, how do we now scale Mount Everest with the same old-fashioned colonial inequitable systems that are still in place, right? If we are still relying on US government funding for HIV treatment in sub-Saharan Africa, for example, and if America is going to completely withdraw from global solidarity, what does that really mean for the new post-pandemic world we're talking about, right? Really, really worrisome trends to think about. So I want to end on a slightly optimistic note. I am pessimistic. I mean, there's no doubt about it because I am worried a lot. The three words come to mind. One is youth, right? I'm not saying that just because I'm talking to students in this class, but I genuinely believe that young people somehow have the ability to see through the bullshit that adults are perpetrating right now. If you look at climate change and the denial of climate change by politicians, and young people like Greta Thunberg can call that bullshit out with great clarity, right? Young people can see much further than people who are not able to see beyond their next election term, right? The adults, I think, are failing us in every walk of life right now. Have the adults not failed us on climate change? The answer is yes. Have the adults not failed us on gun control? The answer is yes. Adults are failing, repeatedly failing in this pandemic as well. So young people are the ones who are able to see that bullshit and call it out. So I really have great hopes for younger people to have a bigger leadership role. Secondly, women. I think women are able to, I think there is already some data that women who've led the COVID response have done way better than men have, right? Women inherently prioritize social impact because they are going through it themselves. They can see things that men are often not able to see, and they're less likely to invest in defense and violent causes or support violent causes. Diversity. If we fundamentally don't change the narrative and make global health more diverse, we would still perpetuate the same old problems that we've been seeing for a long time. And if after this whole Black Lives Matter awareness that we've seen in the last few months, we don't take that advantage of that and fundamentally make equity and diversity a huge part of global health discussion, then I think we would have wasted this entire opportunity, right? There is one good thing that could have come out of all this, as painful as it has been. It's the awareness that things will not change unless people are willing to structurally change the organizations and the agencies that they work in. And that's true in academia, and that's true in any global health organization, right? That's why we need more youth, we need more women, and we need more diversity. And if we could somehow pull this off, I think the world, global health world will become a better place, I think, for all of us to work in. Thank you very much.
Thank you so much for that. I think lots of food for thought. So maybe if you stop sharing your screen, we can see everyone's faces, and then I'll open it up first to the students in case they have any questions to ask. So raise your hands, and then I'll just moderate. So I'll call your name, and then you can unmute yourselves and go. Who would like to go first? Don't be shy. Yeah, Mackenzie.
Hi, thank you. Thank you so much for speaking today. This is a class I was really excited for this semester, and I think is particularly topical with what we've been seeing with Black Lives Matter and understanding how important representation and inclusion are, not just in global health, but I think in everything that's going on. You were talking about publishing, the world of publishing, who's editing, who's writing, who's being published, and who's part of that process. And I was wondering, we do see a lot of things get traced back to funders, and in terms of authorship ranking, is that something that is also tied to funding of who's the PI on the grant application? And if you could speak a little bit more to how the authorship ranking is chosen.
Absolutely. So I think this this mad scramble for lead authorship, I think, is driven by two main forces. One is our own universities, right? If you speak to Claire or Emily or me, we will all tell you that our promotion, our tenure, everything is tied to whether we are in these coveted authorship positions or not. So it puts immense pressure on us to kind of somehow capture that real estate. Secondly, you're absolutely right. As a PI, I need to show productivity, right? And then that then hopefully gets me the next big grant, right? Many of us live grant to grant, right? Especially people who are on soft money, as we call it. And that's very dominant in America, at least. People are under immense pressure to continue to bring money to support their labs and their salaries. And so between all of these two forces, it's very hard, even if we want to be generous and say, okay, this is really not how we want to do things. That's why I think we need to fundamentally change how research dynamics work. So why can't we directly fund good institutions in low and middle income countries, right? The other way to buck this trend is if low and middle income countries invested more in their own research for their own institutions and their own researchers, then they would be less reliant on NIH or Canadian money or DFID money or Gates money, right? So I think both need to happen. We need to find ways to distribute global health monies more equitably and directly to people in low and middle income countries who are doing good work, and for them to fund more. So if an African country funded more malaria research, then they are not beholden to a US or a UK institution for either money or for expertise.
Thank you very much.
Professor Pai, are you able to stay a few minutes past the hour to answer a couple more questions?
Absolutely.
Fantastic. That's so kind of you.
Yeah.
All right. Who wants to go next? Yeah, Madison.
Do you have any advice for students of global health in high-income countries who want to get involved in the work of decolonization but are newer to the field?
I will share through Claire. So a bunch of students in North America and Europe have hosted a series of events on decolonizing global health. They're all available on YouTube, and they're starting to write about a blog about what they have learned. So I think they're all like you. So to that extent, I think you will relate to them better than me telling you what I think. So do read them. I think they have all found it kind of mind-opening to sit through a decolonizing global health event, or what you're doing right now, right? You're taking a whole course. And I have no doubt that it'll open up your mind, every aspect of your mind. It'll make you uncomfortable, I think, if it hasn't already. And I think that's fine. That's what Claire said at the start. If you're not uncomfortable, something's wrong, right? Imagine attending an anti-racism training. Would you think discomfort will not be part of that training? It will, right? It has to, right? So it's fine. So accept it and say, okay, this is how imbalanced things are. And I need to start from acknowledging that there is an issue, right? So in my own global health course, which starts here at McGill in about 2 weeks, I'm starting the entire course with privilege, racism, and colonial history. But I've never done that in the past. And I'm trying to totally change how global health is taught, to begin with those basic building blocks. So read what other students like you have been writing about them. One discomfort, I think, beyond what we've already experienced is the issue that they are asking is, okay, so we are students, we are in Duke or Harvard or whatever, we are very privileged, right? And they get it, right? They are privileged. But they're saying, should we be the ones talking about decolonizing when we ourselves, when we say we, the wider we of the rich world, is the one that has perpetuated these problems in the first place, right? In other words, who gets to talk about decolonizing? Is it the so-called colonizers talking about decolonizing, right? That is the challenge. So it would be very analogous to saying, who should be teaching about anti-racism? A white person or a black person or a person of color, right? It's a very similar conversation that is happening in multiple fields. For example, if there is a course on Indigenous health in Canada, should I be the one teaching it, or should it be an Indigenous person? Mm-hmm. Right? I think that is probably one area where these discussions need to evolve, Because if the privileged people are again talking about decolonizing, or if it's the white people who are talking about racism, then I think it fundamentally doesn't get at the heart of what we are trying to change. So I think it's fine. What you're doing is fine. But I think we all need to start making sure we're not talking within our own privileged echo chamber of what we think is wrong, because then we are no different from others, because they've not been able to get out of that bubble that they've been living in as well, right? So which is why in my own global health class, most of my speakers are not from here now. Because of this pandemic, I could literally take my class to all the countries that I want them to go, and I want them to hear directly from people who are in the front lines, who understand the problem and solutions.
That's great. Thank you so much. And yes, we're trying to get people from based in various different places. The time zone is not always straightforward. Particularly, we realized Oceania is quite challenging to get on at this time.
I know.
We're doing our best.
I know.
And also trying to make sure that we recognize the colonial history of North America, of course, as well as a key part of this.
Yes.
It's not always looking out to global health, but also looking within ourselves and our own environments. Any last couple of questions? Yeah, straight.
Hi, I'm still kind of articulating my question, but I guess before this lecture, what I was thinking about was like, what is the individual process of unlearning? What does it look like in global health? But I think you answered it very, very clearly with your discussion of taking the red pill, especially over the blue pill. I guess my new question is that this individual process of unlearning in global health seems to only really apply to people like us who are interested in global health in the first place. And the pandemic has just showed us that global health affects everyone. So I guess my question to you is it reasonable to expect that people, like that everybody tries to start to adopt this process of unlearning? And if so, how do we spread awareness of that?
So let's be clear, this whole decolonizing global health has come to it very late, right? There are other fields that are way ahead of global health, right? There's a whole discourse on decolonizing science, right? There's a whole course on decolonizing how English language is used to perpetuate certain things, which is totally unfair to huge parts of the world where English is not spoken. So there are people who have been thinking and talking about this for many, many years, decades, in fact. And there's obviously the whole decolonizing of trade and economics, right? Look at the economic ramifications of, yesterday I was talking to a colleague and she told me how some African countries still have to pay a tax to European countries, even in 2020, decades after becoming independent, right? So there's a lot of stuff happening there and how it continues to permeate all aspects of it. But your question really asks an important issue. What is global health? In some ways, global health is a Western creation, right? Because we created it because we wanted some name tag to do what we're doing. We didn't like tropical medicine anymore, right? Because it had that very colonial connotation. And then we came up with, we certainly didn't use colonial medicine or military medicine or missionary medicine. Tropical medicine didn't seem good enough, although some schools still use tropical medicine. And then we came up with international health as a more better way of framing it. And we didn't like that, so we've taken global health. And we somehow think or claim that global health is a better avatar compared to international health or tropical medicine or whatever. But when I was living and working in India for many years, what I did was just my daily work. I never called it global health, right? I worked on TB because I had to see my patients that morning who had TB, right? I worked on leprosy because I had to work on leprosy. There was nothing extraordinary about what I was doing. So global health is just everyday medicine and public health for people on the ground who are practicing it. It just is that when I'm here living and working in Canada, suddenly I'm known as a global health expert because I'm doing TB research back home in India. But in India, I never called my TB research global health. So which itself tells you that one of the reasons why global health is dominated by us is because we came up with the construct to kind of justify our work and do what we are doing. It's not, that's why global health degrees also don't make sense to a lot of people in low and middle income countries. What is a global health degree? They're asking that question. What on earth is this animal? Teach me public health, I understand. Teach me medicine, I understand. Teach me sociology, anthropology. What is this global health animal? And why would I need to get a degree in global health? So in some ways, global health is our construct that we've sold it to ourselves and our students and our donors and our agencies. It does not really necessarily match well with what folks in the front lines are thinking about or doing.
Thank you. Any final questions from the students? Because if not, I have one that I'd like to ask, but I'll open to you first. Okay, so, I was thinking about your representation data, and, obviously in the United States and some other countries, affirmative action has been one effort to try and increase representation and inclusion, but the data have shown, at least again in a North American context, that it's largely benefited white women rather than other minorities or other people who have been targeted. And obviously international organizations to some degree also have pursued affirmative action. Do you see evidence that that same trend is happening in IOs? And what are some of the approaches that we can better achieve that intersectional representation?
So I have a hunch, and I don't think it's based on data or anything like that. It's like we see global health is dominated by white men, white older men in high income countries. Okay, let's start with that. That much is very clear. It's not up for discussion. That's true. So we say, okay, let's first tackle the gender imbalance. So then what happens? You have white men and now you have white women in leadership roles. And we say this is better than what it was. At least we have some progress in the gender. And then we realize that's not enough, because you could have white women leading organizations and you could have serious racism in those organizations, right? Because it's simply not reaching to a level that we want to. Then we say, okay, we need to change this. Now let's talk about intersectionality. And now let's talk about representation from BIPOC people from low and middle income countries. And then we start. So it's almost like it's a huge problem to crack. So we first begin by cracking just the gender problem alone. We wait to act on the other things. And they say, we'll get to that later, right? But I think we have learned by now that if you only attack one facet of a complicated problem, it still fundamentally doesn't leave the structural problems solved, right? It still doesn't cut it. So we have to completely radically rethink it, right? So we have to ask a question. So why is this malaria center located in Georgetown or Toronto or London or whatever? Why is it not in a place surrounded by people working on malaria every day? The minute you do that, then it's driven by people who are dealing with malaria. Diversity automatically comes into the picture. Everything changes, right? So this would require us to do what I had said before, dramatically lean out. And I worry about our ability to lean out. I think we are starting to talk about it, but in practice, it's very challenging to lean out given the structures we have built, given the comfortable position we are all in, and given the privileges we've attained. I would just end with just one reflection or thought. As much as it is hard for, say, younger researchers who are kind of starting their careers, right, versus people who are very established, right? And I ask myself, so if somebody has nothing to lose, they are full professors or whatever, they're heads of the organization, they're famous, they have a long CV, they have a wall covered with awards. Why is it that at least they are not able to lean out, right? Because they have nothing to lose. Think about it, right? Declining to chair a committee or declining to write an editorial or giving up their keynote spot to someone else could be like a second's worth of work for them. and it takes away nothing from their accomplishments or achievements, and yet they continue to hold on to it with their lives, right? To me, at a minimum, I would say that established people in global health who belong in the profile that we're talking about, in high income countries, mostly men, absolutely can lean out. And I think that by itself could have a huge ripple impact on the rest of global health. And I'm not quite sure why this is such a challenge for them. And I think it's true in racism as well, right? If white people simply are unable to lean out and allow that space for people, BIPOC people, then nothing fundamentally changes, right? You still control all the decision making, and fundamentally nothing ever changes.
Thank you so much. I think, that's really good thought to end with to guide our reflection. And really, again, thank you so much for kicking this series off for us. I think this has provided exactly the kind of overview and evidence-based overview. Again, the critical thing here is that we're all coming from a science background, and we need to see this data to understand the depth of the problem. And so that was brilliant. Thank you so much. Again, really appreciate your time. And hopefully, we can continue following your blogs and the rest of your thoughts in this space. And certainly, on behalf of the whole course, just want to thank you all again.
Thank you. It's a real pleasure to be here. Have a good one and stay safe.
Thank you so much.
Thank you.